Good afternoon, everyone, and I really thank AIOS to give me this opportunity to be over here. When we talk about, like, as we were discussing about all anti-VGFs, we had a lot of injections earlier also tried, but we were not satisfying, and still we are not yet satisfied. Still we are trying to search something or the other. But when the brolucizumab came in market, I found it as a game changer, especially for my DME armamentarium. So this is my disclaimer. If we look at the UN resolution, how to fast track to the disasters, like India will spend nearly 3.3 billion to 5.3 billion by 2025 as a treatment cost for diabetes. So 40% more than what it does at present. So this is about the data of diabetes, and as we all know, every one of us might be having one or the other diabetic patient in our family. So out of these diabetics, if we look at the number of diabetic retinopathy patients, they are coming. Nearly 5,000 new cases of blindness per year we are getting reported. And this is how the flow of PDR, severe NPDR and moderate NPDR and mild NPDR is coming up. Are you changing the slide there? So if we talk about the burden of DME therapy on healthcare systems, it's multifactorial. Like DME burden is for declining vision, burden is increasing to declining vision, treatment choices, monitoring needs and treatment regimens. As sir has already said, we have to think of every patient and then think of which drug to be given and how many times to be given. So the treatment burden can lead to adherence and persistence problems also, as we all know. So I would like to come to my cases, what I have gone through in my practice. Till date, I have done nearly 475 cases in 2 years, 2.2 years and 2 months. So this is 68-year male. Can you go to the back, please? 68-year male, diabetic, hypertensive, with mild deranged KFTs, while right eye is 4/60 and left eye is only 3/60, and already had 13 anti-VGFs and IVTA earlier elsewhere. Next, please. So the patient, when presented after these many injections, had this kind of OCT and this kind of OCT with 4/60 vision, and at this point I changed the drug to Paginex. After 3 months he improved to only 660. Still the fluid is there, but the distance between 2 injections was increased. That it's not every month, it's not every 28 days. It's like 3 months we required, and this is a new patient, so I don't have much of a follow-up of this patient right now, yet to come. 38 years male, a very interesting case, judged by profession for the civil court. Diabetic last 5 years, had left eye diminution of vision since 15 days to 6/60 and right eye 6/36. Already had 17 anti-VEGFs in last 2 years with me only, with multiple combinations, permutations, whatever I can do. And at the end, in June 22, we came up with Paginex. So this is my follow-up, how he gone with June 22, then July 22. At first we gave at June, July we just did a follow-up and continued with Nepafenec kind of a drug. And the next injection what I required is in January 23. So my first injection of Paginex, if it is working for 6 months, I will say yes, it's working much better than other drugs, so as to increase the duration in between the injections. And definitely, being a judge, if he is maintaining a good vision, even for professional needs, he is doing well. After January 23, again he reported to us in May 23 for left eye macular edema or left eye diminution of vision, where we required the second injection. And then in August 23, if you look at the gap, at this point we required like 2 months, 3 months gap, while it was for 6 months earlier. And after August, sorry, I'm not able to see. After August, even in October 23, the patient was doing well. And after the October 23, the patient came to us in June 24. Look at the gap in between 2 visits. So the patient is requiring very less injections with a better quality of vision and maintenance of vision, which is much more required for his profession. 35 years female, as sir were discussing about the long-acting drug as the Pagenex is, this case taught us the PRN protocol. Type 1 diabetic with deranging KFT and CRF, only 2/60 was the vision, and she was a treatment naive patient. So if you look at the pre-op OCTs and Octa images, first injection gave, and after post 3 months, she improved from 2/60 to 624, and she remained to 624 post 6 months, even after single injection. But if you look at the OCT, there is a retinal thinning also, macular thinning also. So as sir correctly mentioned, we have to look into, as it is a long-acting drug, okay, it definitely increases the duration between the injections, but as it is a long-acting, you might have foveal thinning at times, so you need to have a close follow-up of your patients. So this was an 52 years female, diabetic 15 years, TRD in one eye where we haven't treated, left eye DME, already lasered retina 3/60, post 18 anti-VEGFs. If you look at this series of OCTs 3/60, 5/60 and only 636, this is 6 months follow-up, but we required only 2 injections, though the fluid is still there. We are still waiting, we haven't injected the 3rd injection because at times there is a study which says fluid at times works for better vision in few of the patients, so we need to calibrate as per the patient needs. 60 years female, male, lasered retina, no uveitis, glaucoma, already had 7 anti-VEGFs, and this was our, from September 2021, April 2022, and this is the last follow-up what we are going to June 24. So in last 2 years, 2 months, we required only 5 injections. So if we are reducing the burden per injection to the patient, we are definitely giving him better vision with low financial burdens also. So adherence to follow-up and treatment, it increases with this kind of treatment. 75% patients receive incomplete treatment because of non-adherence. So as to conclude, definitely brolucizumab resulted highly effective in restoring the anatomy of eyes affected by DME, in stabilizing the visual acuity of both treatment naive and even refractory cases with other anti-VEGFs.
Thank you, Dr. Sangita, for bringing out what we can achieve with newer drugs. I think, as you said already, of course, we don't have that kind of a protocol here where what we talked about loading doses. But I was even trying to talk to many people that even if suppose some people are giving every 2 months, so if we can give in the beginning, say every 2 months and then extend it, I think it may work better. But I do have my own patients, those who were refractory for multiple treatments, even including Ozurdex. They have worked and they are on Pagenex and they are doing very well. So DME is different from, I would say, AMD as far as the use of Pagenex is concerned. Only thing is sometimes I've seen is, I think we should look for the cases, those who have uveitis in past or uveitis cells and other things. I think there we should be careful. Many a time I do write myself there, please avoid Pagenex in those situations because we want to have a safety for ourselves. But great presentation, great cases.
But sir, like in diabetic macular edemas, we need to, like we calibrate the patients. If patient is coming for continuous follow-up and we are observing OCTs continuously, as and when required, we are going ahead because there is a multifactorial disease.
Not only that, I think fluid is tolerated much more in cases of diabetic. It is not damaging as is in cases of AMD. AMD, we don't want that to come back.
Yes.
Here it is, even if we have gap of, and they do have a gap, because they have other systemic issues, as you mentioned, many of our patients having nephropathy, renal transplant, heart issues, others. So I think we have to accept that part. So, but they will not be kind of going for worsening even if we have some gap like that.
Yes.
Thank you.
Thank you so much. Sir, in 475 cases, I haven't.
Not to us. Yes.
In 475 cases, I haven't gone with any IOS, so I'm like 100% confident of using.
Yeah, I think the same thing because you have not gone for loading things, and it's not that it doesn't happen. It can sometimes just happen. We may have some vitritis, some other things, and then it gets controlled. And of course, we have not seen occlusive vasculitis, but of course, we have not gone for that kind of a loading. phenomenon.
definitely we
So
are.
I think we need to generate better protocols and better thing for our own patients here.
Yep.
If we can do that and we collectively have that kind of approach, we may be able to serve much better these kind of, especially patient like in DME.
Yes.
Thank you.
Thank you, sir.
Yes. I have done that because I have had a very bad experience with one of my Sositex patients. Sometimes it happens. He got so crazy, he wanted me to remove it. And he was coming every other day because he got some kind of a thing. No.
Audible, you're not audible.
Ozodex,
Sometimes-
even for patients recalcitrant to Ozodex, he said Paginex.
Yes, it does work in such a situation also. And sometimes it does happen in a patient. It worked very well for him. Paginex was effective, but he was not comfortable with that thing moving inside. He said, there is something in my eye and please take it out. Although my vision is better, but I can't sleep at night. I can't. There are some patients, you see, this may be a rare phenomena, but it can happen sometimes. So I think that's what it works very well in many situations where we have challenges of that kind. Yes.
Thank you.
Patients do see that thing.
Yeah, not all the time.
Ozodex.
Yeah, not all
Like
of
the
them,
patients,
yeah.
they do come up. I just usually say them that like till the time you are seeing this, it will work. After that, it will stop working.
With the new drug Vabysmo that's come out, will your practice change? Will you go for Vabysmo first and then Paginex in such cases?
Actually, you see, the question would be again boiling down to the economy part of the cost. If we go according to the protocol, the way they want us to use and what has been done, that we will be giving 4 injections monthly, and then only we can extend. So I think so all those things boil down to, but then we need to collect data. We need to know. They are harping on one more thing there, that vascular permeability goes down and their vascularity goes down because of so we know that. I think it's too early for us to kind of give verdict on that side.